Hello students, today I'll talk about the tuberculosis and anti-tubercular drugs. Tuberculosis is one of the leading cause of death in HIV patients all over the world. Almost 9 million cases still we have in every year in the world. It is usually caused by the tubercle bacilli, which is from Mycobacterium family. There are three strains of Mycobacterium, M. tuberculosis, M. bovis, and M. africanum, where M. tuberculosis has a prevalence rate 98% compared to other two strains. Usually it is infected by the respiratory route. Infants, adolescents, and immunosuppressed are more susceptible to the various severe form of this disease as miliary TB and meningeal TB. Pulmonary TB is more common than extrapulmonary. In extrapulmonary, like pleura, lymph nodes, pericardium, kidneys, meninges, bones and joints, larynx, skin, intestine, peritoneum and eyes. These all are extrapulmonary. In pulmonary, you have lungs, pleural cavity, mediastinal lymph nodes, larynx, etc. If this disease untreated, 65% of patients dies within 5 years. There are some major symptoms, for example, fatigue, fever, night sweats, weight loss. Weight loss is one of the very important diagnostic symptom for TB. Lately, cough, chest pain, hemoptysis. While go for the diagnosis or the diagnostic test, found the abnormal chest radiographs with pulmonary infiltrations, cavitations and fibrosis. The usual transmission of this disease when the person is exposed to the tubercle bacilli in airborne droplet nuclei, and these droplets provided by the people with pulmonary or respiratory tract tuberculosis. The common incubation period is around 2 to 10 weeks. Usually we have observed that there are some people who are in the risk group for this disease. For example, close contacts, work colleagues from high incidence countries and HIV infected people. There are certain diagnostic methods for tuberculosis. Microbiological investigations, we have microscopy of sputum followed by culture. Can go also go for the chest radiographs and to find out the any kind of color change in the X-rays. One more diagnostic test is called tuberculin skin testing, which is also called as Montauk's test or Mendel-Montauk's test. It is also known as Perquate test or PPD test. Tuberculin is a TB protein or an antigen. Whenever it has been applied to the skin, at least 6 millimeter bleb has to be formed within 48 to 72 hours, and then only it can be considered as test positive. Usually 2 TU of SSI we use it as unit. 2-TUF SSI tuberculin RT23 in 0.1 ml solution for injection can be given. SSI means Statinus Serum Institute. That abbreviation has been given. If you have ever been exposed to the tuberculosis, your skin will react to the antigen by developing a firm red bump at the site within 2 days. If the bleb has been formed, test positive can be considered. Here one thing I want to clear, that anyone who has shown the test positive doesn't mean patient is having the TB infection right now. So more or less this test is not been performed to confirm that there is a TB, but it is definitely confirming that there is no TB infection. Means if there is no any blood form, no further testing is needed. In the chest radiograph, ill-defined opacity in the upper lobe of lung observed. So these way some of the diagnostic tests can performed in the initial level, and then the treatment can be started. Before going into the treatment, I want to explain you one very important point. Usually it has been seen that this bacteria is one of the notorious most bacteria, and this bacteria is notorious in many ways. First thing, it reaches to the various part of your body when it enters in, and goes even in the deeper tissues. The rate of multiplication is even very fast. So any remaining strain in the body even after treatment can survive again as a tuberculosis. So on that basis, because the region where these bacteria are hiding and living in the body are different, the same basis the drugs which we have to treat this infection are having different mechanism of action on the basis of these hiding zones. So let's see what are these, how many zones we can divide here. So we have the 4 different environments where these bacteria are living in human body. First is called open pulmonary cavities. These open pulmonary cavities means we are talking about the lung, has plentiful oxygen and have large number of rapidly growing organisms. So any drug which is effective against rapidly growing organisms will act on this particular environment, and the bacteria which are present in this particular environment, open pulmonary cavities. Second is called closed lesion bacilli. These areas are little more closed, and they are oxygen starved. Because oxygen is less, so the growth of bacteria is less. So here some other kind of antibacterials will act. Third, called intracellular tubercle. Here also very slow growing bacteria strain will be there. Reason is that less oxygen as well as low pH. The last environment, type of environment, is intermittent bacilli. They grows in changing environment, means they are modifying themselves in that way that they can live in changing kind of environment, and there in the condition of the change in pH or the change in oxygen supply, they do survive nicely. If you see the drug like Isoniazid, which is acting on the phase or the environment number 3. If you see the Rifampicin drug, which acts on this phase number 4. So like that, various drugs are acting on the various environment. Just remember this. Now we'll talk about the drug treatment. As you know, we have the different type of tuberculosis, different severity of tuberculosis. and comorbidities with tuberculosis. These all are very important factors to consider before you prescribe any drug or before you make a decision for giving a type of tuberculosis treatment. Here WHO has defined some group of treatments just to give little ease for the prescription. Here I would like to mention these groups to understand better how the treatment schedules have been defined. Group number 1, where first line anti-TB drugs have been given. I will explain you later what are these first line and second line drugs. First line anti-TB drugs are the most potent and best tolerated oral drugs, and these are the most used routinely. Examples: Isoniazid, Rifampicin or Rifampicin, Pyrazinamide and Ethambutol. Group number 2, in this it comes like injectables anti-tuberculosis drugs, anti-tubercular drugs. These are very potent and bactericidal drugs. For example, streptomycin, kanamycin, amikacin and capreomycin. Group number 3, here usually preferred as some fluoroquinolones, which are well tolerated bactericidal oral drugs. Here patients with drug resistant TB should receive one fluoroquinolone in the regimen. Examples: ofloxacin, levofloxacin, moxifloxacin, ciprofloxacin, etc. Now the group number 4, here second line oral anti-TB drugs are preferred. These are less effective, bacteriostatic and more toxic oral drugs for resistant kind of TBs. That's why it has been kept, these drugs have been kept into the second line of treatment. Examples like ethionamide, prothionamide, cycloserine, terizidone and PAS. Group 5, the last group. Here we are keeping those kind of drugs which are having unclear efficacy, not recommended for MDR TB, but may be used in extensively resistant TB, which we call the XDR TB. Examples like thiacetazone, clarithromycin, clofazimine, linezolid, amoxicillin, clavulanate, imipenem and cilastatin. I hope you understand what the groupings, what WHO has done. Now I'll talk about the drugs here. You can see this small classification of drugs, where the first line drugs, for example isoniazid, represented by abbreviation H, ethambutol abbreviated as E, capital E, rifampicin abbreviated by capital R, streptomycin S, pyrazinamide Z. So isoniazid, ethambutol, rifampicin, streptomycin, pyrazinamide, these all are 5 drugs here. These drugs have high anti-tubercular efficacy as well as low toxicity, are used routinely. Second line drugs: thiacetazone, para-aminosalicylic acid, ethionamide, cycloserine, kanamycin, amikacin, capreomycin, and in this there are some newer drugs added, not much newer as well: ciprofloxacin, ofloxacin, clarithromycin, azithromycin and rifabutin. These drugs have either low anti-tubercular efficacy or high toxicity or both. These are used in special circumstances only. Here one treatment schedule is there, for example like 6-month regimen. Here you have initial phase and the continuous phase. Two phases we can give the treatment. Initial phase, 4 drugs for 2 months. Rifampicin, Isoniazid, Pyrazinamide Ethambutol. And in the continuous phase where we reduce into 2 drugs and we give it for 4 months, that is Rifampicin and Isoniazid only. In case of the suspects whom we suspect they have tuberculosis, we can give 4 drug therapy for them. Before going into the detail of all the drugs, I just want to summarize because it is very important to know the ADR of first line drugs. Usually Isoniazid, which has been considered one of the most safe drug, but showing some of the ADRs as hepatitis, cutaneous hypersensitivity, peripheral neuropathy, etc. Rifampicin is showing some hepatitis, some cutaneous reactions, GI reactions, thrombocytopenia, febrile reactions, and flu-like syndromes. While pyrazinamide is showing anorexia, nausea, flushing, these are some common ones, and rarely hepatitis, vomiting, erythralgia, hyperuricemia, cutaneous hypersensitivity, etc. Ethambutol showing retrobulbar neuritis, this little serious one, arthralgia, blurred vision, and altered color vision. Streptomycin is usually showing some nephrotoxic reactions. Whenever we discuss about the anti-tubercular drugs, we have to discuss about the mycobacterium cell wall, because most of the drugs are going to act some part of the mycobacterium cell wall. You have already seen the cell wall biosynthesis and cell walls structure about the when we were discussing about the penicillins or beta lactam drugs. Here a little difference you can observe in the case of the Mycobacterium tuberculosis. This is a common structure of the Mycobacterium cell wall and its composition. It contains relatively thin murine layer just outside the cytoplasmic membrane. The NAM residues of the cell wall in mycobacteria are modified by the addition of a long branched chain consisting of a NAG arabinogalactone linker topped with mycolic acid. You can see that in the structure, arabinogalactone, which is just attached with the mycolic acid. The outer membrane of mycobacterium is thick, asymmetric, and highly impermeable to hydrophilic and hydrophobic substances. So always draw a small structure of mycobacterium cell wall while you are discussing about the anti-tubercular drugs mechanism of action. Now we'll discuss about the first line anti-tubercular drugs, and the first drug what I'm going to discuss here, that is Isoniazid, one of the very important drug, Isoniazid. Isoniazid, which is also called as isonicotinic acid hydrazide or represented as INH. It is very important and essential component of the anti-tubercular regimen. It is primarily tuberculocidal. Fast multiplying organisms are rapidly killed. Quiescent one only inhibited. It acts as an extra as well as intracellular TB. It acts against extracellular as well as intracellular TB. It is found equally active in acidic and alkaline pH. And in this whole tubercular regimen, this is one of the cheapest anti-tubercular drugs and equally effective. It is very important to discuss the mechanism of action of isoniazid. As you can find, the isoniazid is been found interacting with many of the drugs. Isoniazid is active against susceptible bacteria only when they are going to cell division. So it means it is acting on the uh, cell division phase or cell cycle phase. Isoniazid can inhibit the synthesis of mycolic acid, which are a unique fatty acid component of mycobacterial cell wall. This may explain the high selectivity of INH for mycobacteria. Reason is that because the fatty acid component where this drug is acting is only present in the mycobacterium. So reason is that's why this drug is highly effective against mycobacterium. That's why it is been not found to be active against any other kind of microorganisms other than mycobacterium. Here you can find the isoniazid can inhibit the synthesis of mycolic acid, which are essential component of mycobacterial cell wall. How it is doing that? The mycobacterial enzyme catalase peroxidase CatG activates the administered isoniazid to its biological active form. It means isoniazid is acting like a prodrug. Once it goes in, the enzyme catalase peroxidase CatG converts it into the active form. The active form interacts with the INH gene, which encodes for a fatty acid and acid synthase enzyme and blocks the mycolic acid synthase. Now you can understand that it is acting on the active form. This active form is acting on where? On the INH gene. That gene, what that gene does? That gene encodes for a fatty acid synthase. Which fatty acid synthase? That fatty acid synthase which is involved in the biosynthesis of mycolic acid, and this mycolic acid needed for bacterial cell wall synthesis. So I hope you understood. The target sites for the activated isoniazid action are acyl carrier protein ACPM and KASA. What is that? A ketoacyl carrier protein synthetase that block mycolic acid synthesis. So here this has also been explained that what is the target for the isoniazid, where it actually acts. Isoniazid exerts its lethal effect at the target site by forming covalent complexes. So this is a very, very important mechanism for isoniazid. Now we'll see some very potential ADR, what this isoniazid is actually producing. Usually it is well tolerated, but where it is producing the ADR are usually peripheral neuritis, paresthesias, numbness, mental disturbances, rarely convulsions, and most of the time these all are the dose dependent effects. Some minor asymptomatic increase in liver aminotransferase found in 10 to 20% patients, and in some of the patients found fatal hepatitis. Other adverse reactions found: GI intolerance, anemia, rash, tinnitus, urinary retention, etc. Here it is also been found that INH is prone for resistance. So what is the mechanism of resistance behind this? Mutation of the catalase peroxidase gene so that the bacilli do not generate the active metabolite of INH. Simple thing is that if that enzyme is being, the gene for that particular enzyme is been mutated, then there will be no correct enzyme to convert the INH into the active form, and then the INH is no longer effective. INH resistance may also involve mutation in the target INHA gene. So INHA gene can also get mutated. So these are the resistance reasons behind the resistance. As I told you, INH is involved in many drug interactions. Some potential drug interactions are here. It inhibits phenytoin metabolism and potentiate phenytoin toxicity. Aluminum hydroxide inhibits INH absorption. INH inhibits carbamazepine, diazepam, and warfarin metabolism. PAS inhibits INH metabolism and prolongs its T half. Just remember, these are very, very important drug interactions. Now we'll move to the next drug, a very, very important candidate of the anti-tubercular regimen, that is the rifampin, also pronounced as rifampicin, abbreviated as R, capital R. What is this? This is a semi-synthetic derivative of rifamycin B, obtained from Streptomyces mediterranei. Very important mechanism for rifampicin. Usually it's a semi-synthetic derivative, as I told you. Rifampicin is bactericidal to M. tuberculosis and many other gram-positive and gram-negative bacteria like S. aureus and meningitis, H. influenza, E. coli, Klebsiella, Pseudomonas, Proteus, Legionella, etc. It is one of the best drugs for all kind of tubercular bacteria, but it is best acts for the slowly or intermittently dividing ones. Remember initial slides where we discussed about the environments, different environments. Now we'll see what the mechanism of the rifampicin actually does. It is a large lipid soluble molecule that is bactericidal for both intracellular and extracellular microorganisms. Rifampicin binds strongly to the beta subunit of bacterial DNA dependent RNA polymerase and thereby inhibits RNA synthesis. Rifampicin does not affect mammalian polymerase because of its selectivity for the RNA polymerase. I hope you understood. Now we'll see some the resistance how this drug is causing. Rifampicin resistance results from a point mutation or deletion in the repo-B. The gene for the, what is the repo-B? Initially told you, the gene for subunit of RNA polymerase, thereby preventing the binding of RNA polymerase. This is not allowing the binding of RNA polymerase. There are some potential ADR for the rifampicin. Similar to INH, it also has hepatitis, major adverse effects, especially with the pre-existing liver diseases. Dose-related hepatitis usually found. Development of jaundice, require discontinuation. If there is a jaundice have been found, then discontinue the drug. Other serious but rare side effects, adverse effects are respiratory syndrome, breathlessness, maybe with the shock and collapse, purpura, hemolysis, shock and renal failure. Minor ADRs are cutaneous syndromes, flushing, pruritus, rash, redness, and watering of eyes. Flu syndromes also been flu-like syndromes observed. Chills, fever, headache, malaise, bone pain. Some abdominal syndromes like nausea, vomiting, cramps with or without diarrhea. Urine and secretions may become orange red in color. It's a very, very important symptom when the urine and other secretions become orange red in color. So other than tuberculosis, various strain of tuberculosis, it has some other uses. It can be used, like you have seen in INH. INH cannot be used for any other purpose. But here, rifampicin can be used in some cases of leprosy, prophylaxis, for prophylactic use of the meningococcal and H. influenza meningitis and carrier state. Second, third choice drug for MRSA, diphtheroids and Legionella infections. Combinations of doxycycline and rifampicin is the first line therapy of tuberculosis. Now we'll move on to the next drug, another very important drug denoted as capital Z, pyrazinamide. Pyrazinamide, which is chemically similar to INH, because it is chemically similar to INH, so later you can understand the mechanism of action of pyrazinamide is also having a very close resemblance with INH. This drug discovered around same time when the isoniazid discovered. What the mechanism? Because only mechanism is the part which is very important to discuss here. Really, we don't know what kind of which process and pathway it follows to act on its target, but some idea we have that its target is appeared to be mycobacterial fatty acid synthetase involved in mycolic acid biosynthesis. You see, almost every drug is having the action into that cell wall area. The mycobacterial enzyme pyrazinamide converts pyrazinamide to pyrazinoic acid. So here also, like isoniazid has to convert into the active form. Here pyrazinamide has to convert into its active form, and that active form is pyrazinoic acid. It's a very important diagram to explain. You see, the acetyl coenzyme A forms fatty acid, and this fatty acid is involved. It's just shown in a very limited steps. Actually, it's a lengthy, long process. You have already studied before. So fatty acid converts into mycolic acid and phospholipids, and they all are involved in the structure and the composition of the cell wall. Here, if you see the first step, there is a one fatty acid synthase 1 is used, which has been blocked by pyrazinamide. And in the second phase, you can see fatty acid synthase 2, FAS2, is been blocked by isoniazid. So like that, both are acting in the same phase. So why the pyrazinamide and isoniazid are different? This is a difference here. FAS1 is inhibited by pyrazinamide and FAS2 is inhibited by isoniazid. So always remember this very, very potential difference. So pyrazinamide have some more special characters, like is require an acidic environment such as that found in the phagol lysosomes to express its tuberculocidal activity. Pyrazinamide is highly effective on intracellular mycobacteria. Here mode of resistance, here also there is a mutation in the gene PNCA, that encodes pyrazinamide is responsible for drug resistance. So that particular gene mutation is responsible. There are some ADRs where the very important one is the hepatotoxicity. Hyperuricemia is common and is due to inhibition of uric acid secretion in kidneys. So if there will be less secretion, there will be deposition, and that will cause the hyperuricemia. And because of that result, gout can also occur. Other symptoms like other ADRs like arthralgia, flushing, rashes, fever, and loss of diabetic control. That also is the result. Okay, now we'll move on to the next, the last drug of this category, ethambutol, represented as capital E. This is a synthetic water-soluble, selectively tuberculostatic drug, and it is very active against Mycobacterium tuberculosis as well as the other Mycobacterium. But remember, it is not active against other type of bacteria. I mean, it is active against other than Mycobacterium tuberculosis. Means it can act on other strains of Mycobacterium tuberculosis, but not the other type of bacteria. It is more susceptible for fast multiplying bacilli. We'll see the mechanism of ethambutol. It is acting by inhibiting the arabinosyl transferase enzyme that are involved in arabinogalactone synthesis. You remember the diagram structure where I have shown you the cell wall structure. So it is inhibiting actually the arabinogalactone synthesis and to interfere with mycolic acid incorporation in the mycobacterial cell wall. So here you see it's not inhibiting the mycolic acid synthesis, but it is inhibiting the mycolic acid incorporation into bacterial cell wall. Means actually the arrangement process of the bacterial cell wall this drug is affecting, and this way it is inhibiting the cell wall biosynthesis. Resistance it also been caused, usually slow resistance develops in this drug, and main reasons here also the alteration in the drug target gene. Drug resistance related to point mutation in the gene EMB capital B, that encodes the arabinosyl transferases that are involved in mycobacterial cell wall synthesis. So here also that particular enzyme's gene is being mutated. Some very potential ADR, retrobulbar neuritis, impairing visual acuity and red-green color discrimination. This side effect is dose related and reverts slowly once the drug is discontinued. That's why it is contraindicated to the optic neuritic patients. It has mild GI intolerance, allergic reactions, fever, dizziness, and mental confusions are also there. It is also causing hyperuricemia, which is associated with ethambutol use due to decreased renal excretion of urates. Gouty arthritis may result, nausea, rashes, fever, neurological changes are infrequent. Here I would like to mention a little more detail to you. About 10% of mycobacterial infections seen in clinical practices in the USA are caused not by M. tuberculosis or M. tuberculosis complex organisms, but by non-tuberculosis or so-called atypical mycobacteria. These organisms are having distinctive laboratory characteristics, are present in the environment, and are not communicable from person to person. They are less susceptible to anti-tubercular drugs than M. tuberculosis, The drugs which are not effective for tuberculosis are effective for atypical mycobacteria. For example, erythromycin, sulfonamides, and tetracyclines. Resistance is very common uh, to recommend to use combinations. So usually resistance are very common in these bacteria as well. So combination drugs must be used. For more understanding about atypical mycobacteria, please find out the more content and read about it. By this we are completing all important drugs of this chapter. Here there are certain more questions been asked many a time. So I am giving you as an assignment. Streptomycin, you just do the pharmacology of streptomycin, fluoroquinolones, rifabutin, PAS. Other than that, there are some short notes you can prepare. Treatment of tuberculosis, MDR-TB, XDR-TB, tuberculosis in pregnancy, tuberculosis in AIDS, chemoprophylaxis, and the DOT treatment. So just prepare one assignments for this so you get ready with the complete chapter. I hope you understood the tuberculosis and its treatment. Here I am leaving you with this particular slide. Please read it and understand. Thank you so much.